Hello, everyone. I'm Eric Schwartz, President of Refugees International, and it is my distinct pleasure to welcome you to this webinar on the public health crisis in Afghanistan. For an event which we announced only on Friday, the response we have gotten has been significant, which is an indication of the importance of this issue. Not to mention the esteem in which our guests are held. And for this reason, we may take the liberty of extending the session by 10 or 15 minutes. I want to thank Sarah Sheffer, Aviva Schwader, and Irla Atanda of Refugees International for their great work in pulling this event together. And we're just delighted to welcome Dr. Paul Spiegel, who heads the Johns Hopkins University Center for Humanitarian Health. Paul has just returned from 5 weeks in Afghanistan with the World Health Organization and served for most of that time as acting incident manager at the WHO's operational center in Afghanistan. Paul, who we're proud to say is a member of the Refugees International Advisory Council, is recognized internationally for his research and related activities in preventing and responding to complex humanitarian emergencies. And after Paul's presentation, we will hear comments by Dr. Pat Walker, professor of medicine at the University of Minnesota, who has recently served as a tropical medicine and refugee medical health expert at military bases in the United States in the early resettlement effort for Afghans. Dr. Walker has had a distinguished career with areas of focus that include refugee and immigrant health, travel and tropical medicine, globally mobile populations and health disparities. And I'll also say she is my former colleague at the University of Minnesota, or I am her former colleague at the University of Minnesota. I'm also very pleased that Hardin Lang, our Vice President for Policy and Programs, who as a United Nations official spent considerable time in Afghanistan, will moderate and offer some opening remarks as well. So Hardin, the floor is yours.
Thank you, Eric. Before we turn the floor over to Paul, I'd like to set the stage with a short overview of the current situation. Afghanistan is currently teetering on the brink of catastrophe. Some of the drivers, like drought, predate the Taliban victory. However, much of what is happening now directly results from Taliban rule and the Western response to it. Before August, donors supplied 80% of the Afghan government's budget. After Kabul fell, the United States and others froze this funding. In addition, a sanctions regime designed to deny material support to the Taliban is now strangling Afghanistan's public sector. The result has been an economic crash, skyrocketing inflation, and the devaluation of the Afghan currency. The IMF predicts that the country's economy will contract by up to 30%. These events have put Afghanistan on track to become the world's worst humanitarian crisis. As winter unfolds, up to 23 million Afghans could reach crisis or emergency levels of food insecurity. In certain areas, there's a very real possibility of famine. Paul will have more to say about the health system, but the education system is certainly at risk of collapse. What has been the international response? To date, the strategy seems to rely on the use of relief aid to plug the gaping hole left by the collapse of the economy. To this end, donors are now positioning the UN agencies and their NGO partners as a bulwark of sorts against the worst outcomes, pledging $1.65 billion in relief aid this year. This is a sizable sum, but has been quickly outstripped by the needs on the ground. The UN now says Afghanistan will need $4.5 billion in humanitarian assistance in 2022. So donors will need to move quickly to open their wallets. In addition, the UN will need to scale up at warp speed, even as it negotiates operations under the Taliban. But even if aid agencies can pull off a miracle, foodstuffs and medical kits cannot solve the problem. The United States and other donors urgently need to take action in a few areas. One major area of concern is the restoration of basic services. Ways must be found to pay salaries and provide financial support to the public sector. UN agencies have recently launched initiatives to pay teachers and health workers directly, And here I think Paul will have some insights to offer about how these programs work. However, the challenge now is to take these efforts to scale across sectors. Another major area of concern is the liquidity crisis. Sanctions, frozen assets, and aid suspension has conspired to create a massive shortage of paper currency and to cripple the banking system. As a result, Afghans can't access their savings or buy basic commodities, and without dollars, Afghanistan can't import the food and medical supplies it needs to feed and care for the population. There are no shortage of creative ideas about how to tackle these challenges. What appears to be missing is the political will to move quickly and boldly to do the needful. Nowhere is this more true than Afghanistan's health sector. So Paul, can we turn to you to walk us through your trip and help us understand the enormity of the challenge on the ground?
Great. Excuse me. Thank you. Thank you very much, Hardin. And thanks, Eric and Refugees International. Always a pleasure to be affiliated with your group. And thank you as well, Patricia. It's always great, Pat, to be on the same panel with you. I'm going to speak for about 30 minutes. I'm going to start my timer so I will know. There we go. And I'm going to share my screen. Let me know, not yet, I know, give me a second when you can. Maybe I'll look at Hardin to see when it is. Is this correct now? Yeah, you can see everything? Okay.
Yep.
So I'm going to talk for about 30 minutes, as I said, but most of my slides are going to be photos of something that will from my mission and just to discuss what really happened there. Let me see how I can move to my next one. There we go. Okay. So as Eric mentioned, I spent 5 weeks. I came home about a week and a half ago. I was on a WHO surge through GORE and the Global Outbreak and Response Network. And while I was there for about 3 out of the 5 weeks, I was acting incident manager, which basically meant I ran the emergency operations for WHO. It's important because of some of the issues that I'm going to be saying, talking about that Hardin mentioned, that I'm representing myself and not WHO or any other organization. And throughout, I took some pictures. So this, we'll get back to this, but this is the Sorobi District Hospital. And this is right here, a cholera tent, and we'll discuss cholera soon. So one area is security. You know, there's been a lot of reporting about the Taliban and since August 15th. Much of the reporting, understandably, has been negative about the Taliban, and you know that is fair enough. There have been a huge amount of negative aspects that have occurred with what we are not supposed to call them government, but rather de facto authorities, because they have not been recognized by any nation. But there are some facts that I think we need to at least acknowledge. Number one is the security has dramatically improved since the Taliban takeover. There was a lot of fighting back previously between the Afghan government and the Taliban in areas that now the whole country, for the most part, really is under Taliban control. And there's much more access to areas than were previously available. And we'll talk about this when we talk about polio. In an ironic twist, I mean, wherever you will see Taliban very well, perhaps not this fellow, but very well kitted out. There's a lot of American gear everywhere. And when we went to Sorobi District Hospital, we had to have a Taliban convoy, guards, police really ahead of us and after us through with our convoy, because there is still some danger, particularly with international organizations, not really from the Taliban at this point, but through ISIS-K. And you've heard, I'm sure, about the bombings, the large-scale bombings at mosques, and when I was there, a military hospital, but you may not have heard as much about just the daily bombings that are occurring, likely, much of it due to ISIS-K in Kabul and outside, usually metallic IEDs that are put onto cars. So it still is a dangerous situation, and the UN and the NGOs are very, very careful. But for the average person, it is safer. but there are still very clear, there are killings of people who are working either with the Allied forces or with the government previously. So by no means is it is it safe, but there is more access than we've had previously. We were able to meet with the Taliban authorities. We are able to discuss with the Taliban authorities, talk to them about some of their needs. We are also have to be very, very clear because of sanctions that no money will go directly to the Taliban. No money will go directly to any government workers, or let's say de facto authority workers, which means that currently no money can go to teachers who are paid, who are civil servants. No money can go to any civil servants working in the health sector. That being said, if you look on my left, at least I'll use my cursor, this was a mullah, and this is also a mullah who have replaced all the previous government workers. This is the provincial director of health in Kandahar. We were able to travel outside of Kabul to Kandahar as well as Sorobi. He was the shadow provincial health director previously. I think he was in Doha. And while he's not medical, he was very, very well informed and was able to meet with us to go over each of his hospitals, each of the key health centers, what the needs were. He was also very aware of the red lines, so did not ask us for money. He knew that that was not possible. But my meeting with him, at least, was very clear that he was very aware of the needs and he had ideas of what needed to be done. We also met with the governor here of Kandahar. That was just a very perfunctory meeting, but it was interesting to see what some of his needs were as well. So we are able to meet with the Taliban authorities, but for the most part, we make very, very few of any promises, and it's really to try to understand some of their needs and some of the needs of the health system. So I'll talk about Sehat Mandi because one of the main points I want to get across here that I think is a bit more subtle in an op-ed to talk about is that there's a legacy of the health system, and Sehat Mandi is a program that's been going on for now 15, 20 years. It's a program where previously the Afghan Reconstruction Trust Fund, which is funded by World Bank, US government, EU, etc., it provided money to the Ministry of Public Health, and then the Ministry of Public Health outsourced all of the basic services to NGOs. And we've seen this in other countries. And this was a bidding process. I'll discuss this, but I think what's quite important is that because this was outsourced to NGOs, on August 15th, everything just stopped, and there had been no salaries for a couple months previously for a variety of reasons, and everything on August 15th stopped, so that any medications that existed, any materials were quickly used up. So there's now, the donors are restarting, particularly Sehat Mandi, and this can occur, meaning that donors can provide money even with the sanctions, because none of this money is going to the Taliban. All of this money is going, it's now previously the Ministry of Public Health, now it's going through UNICEF and WHO, and then through the UNICEF and WHO, it will be provided to the NGOs. So while I was there, and I'll show you some photos, it restarted, and people were getting salaries, and we're talking in the health centers from the cooks, the cleaners, to nurses, doctors, etc. I'm going to go on to Sehat Mandi, and then I want to differentiate the non-Sehat Mandi services because that's quite important. So one of the big issues in Sehat Mandi, when you read it, it's very impressive. The way it was set out, it was meant to be competitive. There were P for P, which is pay for performance indicators. So a certain amount of money was provided, but then at the end of the quarter, you had to look, there was a third-party monitoring and the Ministry of Public Health monitoring. You had to meet these indicators and then you were paid. And if you didn't meet them, you were not paid, or you were paid less than you were going to be getting paid. But there were a lot of problems with this. And although there have been many improvements due to Sehat Mandi over the last 20 years, there still were a lot of problems. The financial bidding was part of the competitive package. So many NGOs underbid financially, which made it impossible for them to actually provide the services that were needed. The pay for performance focused on 11 indicators, and they used innovative ways to make sure that those indicators were met when some others may not have been. Despite medicine supposed to be free, the out-of-cost expenditures throughout this time in Afghanistan is still approximately 80% out of pocket, which means this is problematic, that not all the money that was going into the health, the running of the health centers. And we've all read about it, but the legendary corruption in the government, the previous governments, is quite extraordinary. And the transparency issues that we learned about with Sehat Mandi were quite disturbing. And also related to the data, I think, although there are a lot of quotations and about what data and in terms of maternal mortality, when you dig deeper, some of the data are questionable because the people who are collecting the data were under a tremendous amount of local pressure to make sure that that the data were in such a way that it would not affect the financing of the system. So there were problems, there's no question. On the other hand, now we've seen that it is starting up again, and it's essential for the Afghan people. We're talking about community health centers, basic health centers, comprehensive health centers, up until district hospitals. Now they're starting to function again as of November, thanks to WHO and UNICEF and the NGOs. Big problems in terms of infrastructure. So this is just some pictures of some medicines that were flown in by WHO. The borders are not necessarily open. The Taliban don't want a lot of people fleeing across into Pakistan, and there's questionable on both sides in terms of allowing people to move. So it's been very difficult to actually bring supplies in. On top of that, as Hardin mentioned, liquidity. The banking system is frozen because of the sanctions, and there's no money coming in, basically, or very, very little. And so even if some of the recommendations that I have were able to be undertaken in terms of providing humanitarian exceptions to the sanctions, if we don't address the financial system, even many of those, and for education, for livelihoods, will not be dealt with. So this was an example in Sorobi district, which is about 2.5 hours, an hour and a half, 2 hours outside of Kabul, through a very remote area, and it's a road that can be quite dangerous in the past. But we were able to see, for example, this is a health center. They started to receive funds in November. We were very pleased to see a midwife. She said that throughout she's been coming. And that is something else that I want to say throughout, even though many had not received salaries for 3 or 4 months, pretty consistently, people, the doctors, the nurses, even the cleaners and the cooks were all coming, I think, for a variety of reasons. One, they had a commitment to make sure that this occurs. Number two is they were hoping that they would eventually get paid. And number three, there weren't many other options, because everything, because of the economic effects, just stopped in August 15th. So they didn't have a lot of other alternatives. That being said, they're coming, and it was quite extraordinary that they came, but it was quite demoralizing, because for many months they hadn't been paid and there was no medicines. So this was a WHO mission that I was on, and at least you can see here that there were now finally medicines restocked. And this is one of the doctors there, and we were able to see what he was doing at a basic primary healthcare center. It was refunctioning again. The problem is that it's such economic dire straits right now that people don't have enough money even to afford a bus, a taxi to transport to actually get to many of these health centers. It's that bad. So while we may be addressing at the basic primary healthcare level supply issues, meaning now Sehat Mandi is being funded and it will continue to be funded by the Afghan Trust Fund and the World Bank at least until June of next year, questions about access will remain throughout Afghanistan because of lack of people able to even afford transport, amongst other areas. Now we have the Sahet Mandi versus the other emergencies. And one of the issues that has come up is that, number one, all agencies, UN, NGOs, there's limited capacity in country right now across the board compared to the needs. They've scaled up, but the needs are so big that it's very, very hard. So one has to make very prioritize and make very difficult decisions. Getting Sahet Mandi restarted was clearly the first priority. It did mean that we weren't able to address everything else as well as we would like. One area I want to talk about is the non-Sahet Mandi hospitals, because it's not clear, I think, to many people. They think, okay, Sahet Mandi, the basic healthcare services are now restarting. Problem is that Sahet Mandi is only for these NGOs. And in the legacy of the system, you had provincial hospitals, regional hospitals, most hospitals in Kabul. And then in the last year and a half or so, because of COVID, there were 39 COVID hospitals. So in total, there are approximately 67 provincial hospitals up and another 39 COVID hospitals. Some of them are part of existing hospitals. No funding, because of sanctions, is allowed to get to these hospitals because they are considered government hospitals, and the people that work there, government employees, because in the past, money came to the Ministry of Public Health and the Ministry of Public Health paid them, unlike with the basic health care where the money came to the Ministry of Public Health. The Ministry of Public Health gave that money to the NGOs, who then paid their workers. So the workers in the basic health centers are considered not government employees, but those in the hospitals are. And the effects are just horrendous, and I'll talk about that shortly. Relating to that, there are 6 simultaneous epidemics. I'll discuss some of those. And then there's a myriad of other issues that need to be examined. There are so-called white zones, and what these are were either the very sparse rural areas and or the areas that the Taliban controlled where there was limited access in the past. So these were emergency areas with a lot of mobile health teams. Now we have some access in some areas, and we need to expand to there. Lots of questions about internally displaced persons, either currently and or what may happen. We need to prepare and provide for them. Trauma care is still a major issue. The amount of conflict affected trauma has reduced because the fighting has reduced, but it's still there because of ISIS-K. But on top of that, you've got an increase in road accidents and other trauma that needs to be addressed. And then there's a whole hugely important area in terms of non-communicable diseases, mental health issues that need to be addressed. And it is just impossible right now to address all of these. So part of the job, and when I was there, at least working with others, was to make decisions of what we could actually address. Here's an infectious disease hospital in Kabul. This is the premier hospital for Afghanistan. We've spent time with the director. He has not been paid, and no one in this hospital has been paid for 4 months. There are hardly any medicines there. I went to see the ICU, and I mean, the ICU is not really an ICU, and even all of the ventilators that were previously there have been moved to nearby to an Afghan Japan hospital, which is the referral COVID hospital in the country. That hospital is limping along because no one's been paid, and they don't have sufficient oxygen and certain medications. So it's a major, major issue when you have a health system now, a nascent, at least basic health system that is starting up, and you have none of these other hospitals that are working. This hospital was so bad that, well, there were no food for patients, and it's getting cold. And normally, this was in late November, but normally there's snow on the ground, and snow is inevitable to become very soon. They don't have enough money for heating the hospital. And so they were literally, the director was saying they were cutting down trees in the courtyard to be able to try to just heat some of the rooms. This is a well-known famous hospital, Mirwais Regional Hospital in Kandahar. Same issue of no money, very little money. Luckily, this and some other, a hospital has been supported by ICRC in the past. And the only organization that has really said at this point, we're going to be supporting some of these hospitals is ICRC. They started with 17, I believe they're up to 23 now. but that leaves still not hundreds. It leaves approximately 60 or so that are not being supported at all, and they're on their knees. And this is because of the unclarity. Well, sanctions say they cannot, donors say they cannot. The US government and others are working on to try to provide some clarity of what can be under humanitarian sanctions. But still the problem is, because these are government hospitals, the sanctions say very clearly that government workers cannot be paid. So there should be able to be some workarounds, but currently that's not happening. Here was an example of a functioning COVID-19 hospital in Kandahar. The top part was the COVID hospital. And even this had a functioning machine that was able to do oxygen. However, this is quite far out from downtown Kandahar. It was built a couple of years, I think about 10 years ago. And the numbers are very, very low, people that are coming there. It's unclear if it's low because COVID-19 right now. There have been at least 2 big waves in Afghanistan. So it's unclear about the transmission is low, or because people are just not able to afford, and ambulances are hardly working so that people aren't there. I'll get into the surveillance, but it's problematic. So one of the things that we did early on, because we did not have, I think, a very clear way of trying to assess the functionality of COVID hospitals. So we visited all 39 COVID hospitals. We looked at the number of health staff that were still there. We looked at the availability of medicines, 5 critical medicines. We looked at oxygen supply. This was something else, so we can ignore. That was just trying to look at trends of patients. And we looked at fuel availability. And from that, we were able to look at what hospitals are functional and what hospitals are not functional. And when we did this, we ended up getting a very different picture from what was being reported. So only 3 out of the 39 were actually fully functional. Many were partially functional, closed 6, not functional 8, and then we needed more information on some. And this was able to portray to us the devastation of what is happening in terms of just COVID hospitals alone. There are 6 simultaneous epidemics, and you can read them here. On top of that, surveillance, most of surveillance was paid through the Ministry of Public Health. Thus, these were government workers. So these people here are part of a rapid response team. He's the doctor actually of the hospital, and then these are the rapid response team, and he leads the rapid response team. They haven't been paid for over 4 months. Most of the surveillance they're doing is community. Is health facility based, not community based. They have to pay even their own money. These are some COVID samples that they collected, and they have to pay their own money on their scooters or their motorcycles to even go to the lab to drop them off. Consequently, we're seeing that there's only there's very limited numbers, about 2,300 to 800 per week of COVID tests that are being done in a country of 38 million. Bottom line is we really do not know the situation in COVID. It's going to likely get worse in winter, and we can't even test right now genetic testing for Omicron. Have about 8 minutes or so left. I want to talk about acute watery diarrhea and cholera. Acute watery diarrhea, unfortunately, the Taliban are not allowing anyone to call this cholera. This is what happened years ago in Ethiopia and other countries. It is cholera. We've been able to culture samples. We can see in a very short period of time, this started September 12th, I believe. There have been 4,688 suspected cases in 5 provinces. What we are seeing, though, is that it's now being stabilized, and it's mostly occurring in Kabul and Sorobi. And we think because of winter, we're going to be able to address this current outbreak. The big concern is with the devastating economic situation, water infrastructure and sanitation infrastructure, which was already very poor, is crumbling. And I think many of us are concerned when cholera will reappear after winter. How will we control this? And we need to avoid a Yemen-like cholera outbreak, but I'm very concerned that there won't be the funding or the preparedness or the prioritization to even make this occur. This was just some of the mapping that we did because this needed to be done, and we were able to work with UNICEF and WHO to try to start mapping all of this, understanding where the hospitals were that were seeing these patients, recognizing that many were private hospitals, and then having to go to them to understand how are they actually dealing with the cholera. This was Sorobi District Hospital, as I mentioned. This is where much of the cholera was occurring. It was insufficient. They needed more training. They needed proper media to be able to culture. These were just some examples. They had a rapid diagnostic test, but they didn't have the correct media, Carrie Blair, that was needed to actually address the cholera. Just one example of, and multiply that by tens of thousands of the needs within Afghanistan. And you can perhaps see some of the areas. I'll skip some of these because of time, but dengue, which was originally in the last 10 years or so, not endemic to cholera, it was to Afghanistan, it was coming over from Pakistan. There are cases there. There are now more and more cases, up to 700. There are measles cases, and this is very concerning. This really means total suspected cases. This is just from the 513 surveillance sites. Another database shows that over 65,000 cases thus far. This is a comparison of measles in the past, and this is 2021. This measles, combined with a severe acute malnutrition in the country, means that there will be an incredible amount, sadly, of deaths to occur. There wasn't enough time to or measles vaccinations at the time to do a full measles campaign. So while we were there, we targeted 6 provinces and combined it with polio. But because the whole country is at risk right now, not just of measles, but of all the vaccine preventable diseases like pertussis and diphtheria, and because we won't likely get to this till January and February, the concerns about epidemics are extremely high. I've talked about COVID, so I won't go into too much detail other than to say for example, last week, there were labs in both private and public, so 7,202, but we don't get the reports from the private labs. So out of the samples tested, there were only 2,026 in the whole country. I mean, can you imagine how can one actually have a surveillance system and understand what is happening there? COVID vaccine is limited, but there still has been 12%, which for Afghanistan, I'm happy that it is at least there, but it's not nearly enough. Most of it is J&J, and we do not know if Omicron is there at this point. It would be surprising if it is not, if it will come quite soon. And there's a lot of concern now about a big wave of COVID of which we are not prepared. And I will end perhaps by just talking a little bit about some of the issues that are coming up. I'm just going to close this so I don't hit my bell. So the system truly is close to collapse. I would say it's nearly collapsed at this point. And because winter is coming and is here there already in many places, there really needs to be some immediate changes to occur, and I'll go through some of them. One of them is that, yes, the sanctions are there, and for a variety of reasons, both the UN sanctions and the American sanctions, they're not going to stop. But there are examples in Venezuela and Yemen and other situations where sanctions can be modified, particularly they can be exceptions for humanitarian reasons. The problem, though, is that many countries are not clear, both countries like the EU and many of the NGOs, many of the donors are not clear of what sort of response they will have if they start using funds in certain areas, because the US government has not made it clear what can and cannot be used in which situations. They have made it clear currently that no government employees, no civil servants can be paid. So that means that these provincial hospitals and above no money can come to them. I think many people believe there should be a way to have a workaround. You could even go so far as to put these people on special leave without pay, and then have the NGOs hire them. Therefore, they're no longer civil servants. This needs to be done ASAP. The second thing that needs to be done is we need to improve surveillance in the country, and we need to provide funding to a functional Ministry of Public Health. Again, they're government workers, but there needs to be a workaround because the Ministry of Public Health monitoring and evaluation, what they do, surveillance is essential to a country. It's the glue that can allow these health systems to function. So that needs to be done. And then finally, one of the most important, actually, I would say two final things. One is capacity. We actually need humanitarian workers to go to Afghanistan. It's not easy to get people to go, particularly for a longer period of time. All of us, I think, are worried about the capacity and the security, but we need more people here because capacity in Afghanistan, the capacity is limited. There are many very, very competent nationals who are working in Afghanistan. One of the concerns is that if we hire all of the Ministry of Public Health people who are not getting salaries right now, but if we hire them away and they're very competent, what happens to the future in the Ministry of Public Health? On a personal level, of course, if you're that person, you need to feed your family. And then finally, none of this will be done if we don't address some of the central bank issues, the issues of liquidity. And we had a very nice discussion yesterday specifically on this issue. It's an area that is far beyond my level of expertise, but we had difficulties sufficiently paying polio workers, the measles campaign and others, and the NGOs with Sahat Monday, because there just is not enough money in a system. And it's not good enough to say just we'll be using electronic money, because Afghanistan is a cash society and these people need to be able to take out money to be able to pay just for daily living. I'm going to stop there. I hope to have conversations and questions from you, and thank you very much.
Thanks very much, Paul. You paint a pretty clear-eyed but very grim picture of what's in front of us. Patricia, can I turn to you now for your reactions and insights, and then we'll move into the questions and answers. I would say, for the audience members, if you have a question, please go ahead and enter it in the Q&A function at the bottom of your screen, and we'll start to collect them and get that ready for our discussion afterwards. Okay, Patricia, over to you.
Thank you, Hardin, and thank you, Eric, for Refugees International pulling this really important webinar together. And Paul, as you said, it's always a pleasure to listen to you, to learn from you. So I want to thank you. I'll just make a few comments. Thank you for that really outstanding and obviously very sobering, on the ground account of the realities of life in Afghanistan today. So the first comment I'd make is really a reflection on the question which is at the core of this webinar, which is, how do we move forward in Afghanistan? And one would think that, we could choose to move forward by recognizing our moral debt. And I know that there's been quite a bit written about that. But if that's not adequate to generate change in political decisions, particularly, as you said, having our government clarify and perhaps have exceptions to or workarounds in relationship to sanctions, then I think one of the things we have to do is recognize the consequences of failure, which is what you were describing, Paul, the reality of extraordinary suffering and death. And then also to remind ourselves that we will lose gains of the past 20 years in Afghanistan in terms of advances in health, support for the health sector, and certainly advances for women, with lots of discussion about that. If that sense of moral responsibility doesn't engender change, then I personally feel that our advocacy efforts as a US and international community should focus on the global political and health security agendas and those consequences. So a few of those just to think about is externalization of the crisis, spillover, a refugee surge in the region and perhaps into Europe, perhaps increased risk of support for extremism in the region, and also obvious concerns about an increased risk for backlash from extremists in the US or extremists elsewhere, an increased risk of COVID spread, polio spread, other communicable disease spread, and then the downstream public health, political, and financial implications for nations in the region, but as well as other receiving nations in the US and Europe. I'll speak very briefly about the domestic side here in the US, that we are dealing with the expected consequences of caring for a population that came immediately from a war zone. This really is historic. It's not our usual refugee resettlement process with mechanisms in place internationally to help with health issues. So it's not surprising, Paul, to hear your descriptions of the situation in Afghanistan today and see that reflected in what we're seeing at the US safe haven sites. So outbreaks of vaccine preventable diseases, including measles, that stopped flow of refugees, humanitarian parolees and SIVs, particularly for 21 days in September, outbreaks of chickenpox, significant amounts of COVID. Our COVID positivity rate was only about 0.4% at the base where I was working in New Jersey, but that's still quite a large number of people. And that resulted in just exactly what needs to happen in Afghanistan, which is this mass immunization campaign. So we vaccinated people for MMR, for varicella, for polio, for COVID, for other age-appropriate vaccines. We're seeing malaria, we're seeing cutaneous leishmaniasis, we're seeing TB, including MDR TB. So what you would expect, and the reason I bring this point up is explaining, of course, as you all know, that we're so connected. So that what happens in Afghanistan or other places where there are humanitarian crises will impact us around the world. So I'll end just by saying that I think that what we have learned so clearly and sometimes very painfully over decades of work internationally and domestically is that these upstream public health interventions are obviously the right thing to do in the middle of a humanitarian crisis. But in the case of Afghanistan, as you outlined so eloquently, Paul, it's not just a humanitarian emergency, it's literally the collapse of an entire country, the health sector, the financial sector, education. So investments in Afghanistan now clearly are the wisest long-term moral, the long-term political, long-term financial health decisions to make not only for Afghanistan, but for the region and for the world. And as Bill Foege said, the former CDC director, and as I like to call him, smallpox warrior, once said, every public health decision is made on a political decision. So thank you again very much for your work and for this conversation today.
Patricia, thank you very much. And thanks for your service on the base in New Jersey and elsewhere. You raised this question about, Patricia, about externalization of the crisis. And if I sort of latch back to Paul's, 4 or 5 priorities that he outlined, getting the wages paid, surveillance, scale up of the international aid effort, working the liquidity issue, those are big, thorny challenges and issues there. How do we think about, Paul, from your time on the ground, if you think about those sets of issues, trying to, and what has to be done before we get to a point of a massive externalization of the crisis, people leaving, flowing into the region, et cetera, where perhaps they can get food, shelter. How do we think about the question of time?
Yeah. And I'm also reading some of the questions there as well, but we'll get to them. After some conversations we've had the last few days, I'm actually worried that we're out of time already, or that it's passed, because we're not asking an end to sanctions. We're not asking for a recognition of the Taliban, because we know that's not going to happen, at least currently, and there's some huge political implications. But because the crux of everything, I think, will be the financial system, because as Pat just said, I talked about health, but there's education, there's every other sector. So they're all, priority. If we're not going to deal with some of the central bank issues and liquidity, and I don't get the impression that the US and the others are going to be doing that in a time in the next few months. And so I hope I'm wrong, but my feeling is that this is going to get, both in terms of numbers of deaths, and then there likely in the next few months will be some larger scale migration. And I worry because we have an opportunity now to do something, and we always seem, as most countries, respond only when we see the pictures of people dying. And we can show them to you now because it's already happening in Afghanistan, but I think we have to examine the political the political implications of doing nothing, but also I think we have to be realistic politically in terms of what the current administration, what they're thinking about in the midterms in 2020, and all of these decisions are impacting the lack of clarity, I think, right now coming from the administration.
Thanks, Paul. Let's turn to some audience questions. The first one is, what evidence is there on the ground of donor coordination, or conversely, donor dysfunction, in supporting the health sector and health provision?
Yeah, and thanks, Alistair. I've worked with Alistair in the past. The donors currently, the donors are working together, and I must say, we have numerous donor meetings with the EU, with US, Canada, Australia, and the bank. I think the donors, at least the many that we are working with, clearly are upset about what's happening, but they have to follow their governments and what the governments are saying. So there's coordination amongst them. But, and I think, as I said, the people I'm dealing with, we were dealing with who deal in health, recognize there have to be workarounds or we're going to get into a lot of trouble. That being said, we had numerous meetings where donors were talking about and making sure where our money was going and that it was not going to certain areas, hospitals, etc., because that's currently what the understanding is. So I don't believe there's much as in other situations. I think the donors are trying to do their best to try to help, but with the lack of clarity and the sanctions and the potential serious punishments, both legal and financial, they're not able to do what they're doing the best they can, but it's not enough.
Maybe I'll tackle another question, which is, how do we include Afghans in this discussion? I work with so many highly qualified MDs and public health trained Afghans that have made it here. Why are they not featured as the primary voice in these conversations? And I would just say we are very aware of our Afghan colleagues who are physicians and are engaging them. One of my colleagues, Dr. Maria Syed Shah, for example, here at the University of Minnesota, has put together an incredible webinar on introduction to Afghan history, Afghan cultural considerations in caring for patients. So I would encourage everyone on the webinar to look at the University of Minnesota Center for Global Health and Social Responsibility website. We have incredible resources with frequently asked questions about the Afghan diaspora here in America. I think it's a much harder issue. I will tell you, my colleagues who are Afghani have said, I am thinking about how to help here in the US, but I'm thinking much more about the disaster unfolding back home. And I feel helpless to help in any way in that regard. So I do think it's very important, obviously, to look to Afghans for answers as well here in the US.
That's great. Thank you very much. A couple other questions have come through. One on sort of preparations in the region. What about regional and third country, not US or Afghanistan, needs, given that so many refugees are already in Pakistan and Iran in particular? I mean, I think that this issue, Paul and Patricia, please jump in, but I think this issue needs to be really front and center. If you look at sort of aid budgets into Afghanistan, the numbers have been quite high, in recent years, and even, over in response to the post-August situation. However, the aid effort to support the refugee response in the region still remains fairly low. And I think there are, Iran, Pakistan don't have a lot of faith that they're going to be getting the kind of support that would be necessary, particularly long-term and consistent support that would be necessary to facilitate this. And I also have the sense that they're looking at whether or not Western countries are really going to make good or even enter into commitments around resettlement to sort of share the responsibility moving forward.
Yeah, I'll start maybe on my past before Hopkins. I was 15 years with UNHCR, the High Commissioner for Refugees, and I spent a lot of time both in Iran and Pakistan with the Afghan refugees. And I would say number one is, as with nearly every other refugee hosting country, there's not enough support. They take most of the both financial and other aspects that come with hosting refugees. So there is not enough support. My understanding and talking to people in all these countries is that I think, given the history of what has happened, they are not going to accept a tremendous amount of refugees in their countries. Maybe they will let them, if they let them in, I think, and Turkey as well, we will see an outflow into, particularly in Europe and other areas. And there was a meeting last week where I think with IOM and UNHCR, where the Taliban spokesperson said that clearly. So I do think we need to think of the ramifications. Pakistan and Iran in particular are already hosting so many refugees. There will be a major problem, I think, for Europe, but not a problem, but they will naturally move towards there. I think resettlement to the US is hugely important, but this is always relative to the overall population and needs is very limited. So yes, we in the US need to continue to resettle more Afghans, but the real issue right now, I believe, is to try to reduce the possibility of that outflow. And that means a tremendous amount of money and concentration on Afghanistan herself.
I'd maybe make one more comment. I really agree with you that US resettlement is not the long-term answer for millions of people. And one thing I'd share from my previous experience in Southeast Asia is that Thailand, as you know, was a major country of first asylum for decades. And the other comment I'd make is crises like these go on for decades. This won't end in a year. And if IOs and NGOs work extensively with the government of neighboring countries, including significant financial incentives, then I think that obviously can help in terms of supporting the acceptance of refugees. I'll give you a specific example in Thailand that they made a decision that the organizations working in the country had to use Thai pharmaceuticals. So it's a very positive thing for Thailand in terms of their finances for their pharmaceutical industry. But those are the kinds of things that you can do and that Paul knows so well in terms of supporting neighboring countries in efforts like these. And I do think it will go on for a long time.
Yeah, I mean, I think that we're definitely taking the long view of the situation moving forward. Another question from Arash about what is the single biggest, most important policy ask you would have of the Biden administration in terms of the issues you've raised, liquidity, sanctions, et cetera? This is what is the number one issue that we need to tackle, or what are the order of priority to the extent that it's possible to set that?
I think the number one issue is liquidity and a functioning central bank so that money can actually flow into Afghanistan. It cannot right now, and it can't. And as someone eloquently pointed out last evening in a conversation, it can't just be electronic money. It has to be physical cash, Afghanis, to get there, and that's going to be extremely difficult to do. So that will open up a tremendous amount of possibilities to respond. But I think realistically, that's going to take much more time. It's not going to happen in the next few months to the level. There are a lot of innovative ways that economists and others are thinking about through swaps and other aspects. That's great, but the more the merrier, but it's going to be not address the overall need. So I think the second aspect would be that is probably more realistic and more timely in manner is to figure out a way that healthcare workers, teachers, and others can actually want to teach and want to come into want to actually do their job and help the Afghans can actually get salaries. And that requires a workaround while not breaking the sanctions, the US government and others making it clear that this can happen. And yes, liquidity will still be a problem, but compared to some of the other issues, certainly paying of salaries is possible to do. We're talking hundreds of millions of dollars to be able to do that for a few months, as opposed to billions of dollars that is ultimately needed.
Paul, can I ask a follow-up question about that? I know that in many refugee settings, and I think you published on this earlier, that if you provide refugees with cash, that outcomes are better, because especially thinking about women as the people in the family who are doing the most around health, is that a possibility in Afghanistan? And do you think it's a good choice?
It is being looked at, and recently the U.S. did state that remittances can occur. The problem right now is that the need and the liquidity is so bad that there isn't enough money in the banks. So even if we're transferring to our family in Afghanistan, they're not able. And especially if you do it at a large scale, there won't be enough money to be able to deal with this. That is hugely important. The other thing I wanted to bring up, which is really difficult to bring up because the way the Taliban and others have been treating women, minorities is completely unacceptable. And I think we all, most would recognize that. The issue though is that I was there in 1996 when the Taliban first took over there. I was there for 6 weeks, 2 weeks before the Taliban took over in 96. Currently, the Taliban are not homogenous, but they're not the same as they were previously, and that may change. Right now, I think they're playing nice with the international community because they're hoping and they need this money. But we are seeing some flexibility, and it depends on the line, but it depends on how inflexible we want to be. But certainly, as a human rights person spoke to last evening, the human rights and the health and the education, we're all together right now because we treating women and minorities and ensuring that they are treated properly and equally is hugely important. We don't want to put that aside, but we also need to make sure that we can address some of these key issues now. And working with technocrats, working with government teachers is not supporting the Taliban. Most of these people are civil servants, and they do or do not support the Taliban. We don't know, but they're technocrats. These are the people that we need to be able to continue with their work, and they need to receive salaries. That has to happen. And I think many of the concerns we have is that if we continue like this, the Taliban, and there's a split within the Taliban that we know about, and the Haqqanis and some of the others that are much more conservative and may not want to work with the West, may very quickly say, enough, we're not going to continue this at all. And so even some advantages that we could have to make changes may close very soon if we don't do something.
Thank you both. Apropos of your comments, Paul, about sort of the human rights record, especially of the Taliban, we just had a question in the chat about the role of women in the health sector. What observations do you have given your time there? And it was pointed out that most of your photographs are of men. Were they playing a role in a serious and significant way?
Yeah, very much. Most of my photographs were of men, primarily because I'm very careful of taking photographs of women in Afghanistan. But the Taliban early on decided that their women working in hospitals, we're talking from cleaners, cooks to doctors and nurses, can go, and they were encouraging them to go. We've been doing a bunch of different surveys, and for the most part, they have been going. And where we met, where was it? In one of the hospitals, one of the comprehensive health centers, we met 2 women that were still continuing, and 2 female doctors that were there and working. They hadn't been paid like everyone else. So, well, it may not be, some women in some areas may have decided not to go because of their concerns or in terms of security. For the most part, at least from what I saw personally, but also in the surveys that we were doing, women were going. They have big concerns about, like a lot of them, about transport because they're not getting paid. And so they're very concerned that even just to pay to actually get to work, but this is all people, not just women. And then there was a lot of discussion about, can men in certain areas treat women? Can male doctors, male nurses treat women? And there was a lot of, it depends on the situation, but it was not a cut and dried no. For example, in COVID hospitals, that was possibility. Anything related to maternal child health, no, it has to be women. So I would say overall, what we saw was not in the health sector, not negative in that way. And in the Kandahar area, which is Taliban area, we met, as I showed, we met some women doctors and nurses and midwives, and they were mentioning that they're still actually allowed. They're giving out they are family planning. They're able to do that in the Taliban areas. And we said we were surprised, and they said no, most of the women that are coming are actually wives of the Taliban, and we saw specifically the family planning materials. So that was interesting to see, but again, that's more anecdotal than anything else, because I was not able to go to a huge amount of areas.
Thank you very much. I think we're getting pretty close to time. Would you mind that if I sort of turn over very quickly to Patricia, if you have any final comments that you'd like to sort of make, and then turn to you, Paul, as well, and then we'll go to Eric, our president and CEO, who's now joined us.
Yeah, just to thank you again, Paul, for all your work. And as we all know, the global is local in healthcare, and what's happening in Afghanistan should make us all very anxious and also committed to changing, because one of the things I appreciate so much is this capacity to think outside the box and think of innovative solutions, and to know that we can do much more than we are doing. So thank you for your work.
Paul, any parting shots?
Just to say thank you for the opportunity, and most importantly, why I really do want to have been speaking out is that the situation is untenable. I mean, this is really, really serious, and we have a very limited time to do something. And so I appreciate the advocacy that Refugees International is and will continue to do. And I hope that we can continue to at least to bring either some of the data and the stories, and to really be able to elucidate what's happening in the field, so that we can help to add some of the pressure to make some change. Thank you.
I just want to make one comment and then thanks. The comment is that the disconnect, the disparity, the chasm between the desperation that we are likely to see shortly in Afghanistan on the one hand, and the political will that will be so necessary to address these sets of issues is just so profound that sessions like this are so important to educate and to give organizations, individuals, civil society, government, those in government who care about these issues, the capacity to push very hard as we possibly can, and we will. Indeed, in the days, the weeks, the months ahead. I want to thank our Vice President for Policy and Programs, Hardin Lang. I can't think of two individuals, Dr. Paul Spiegel and Dr. Pat Walker. I can't think of two individuals whom I'd more prefer to have joined us for this session. Paul, for your firsthand work and experience, and Pat, for your perspectives and experience. And it's wonderful to see an old colleague. I will confess, Paul, that I did encourage students at the University of Minnesota to go to the School of Public Health there, but when they chose Bloomberg, I didn't complain. I just want to thank all of those who came on a Tuesday night just before the holiday to join us. And again, thanks to you all. And we will continue to be seriously, strongly engaged on these critical issues. Thanks again, everyone, for coming.
Thank you, everyone.
Thank you very much.